Hello, good morning, everyone. Thank you for joining us for our Research in Progress webinar series. My name is Dina Brosi. I'm a professional research assistant at the Systems for Action, and I'm going to be your moderator for today. And we're going to be talking about aligning behavioral health and child welfare systems to address the opioid crisis in Ohio. A little bit of an introduction for S4A for those who need it. Systems for Action is a research program funded by the Robert Wood Johnson Foundation that builds a culture of health by rigorously testing new ways of connecting the nation's fragmented medical, social, and public health system. And our S4A webinar is a great chance for us to hear from research studies being conducted throughout the program. Systems for Action funds studies across the nation that test novel strategies of aligning delivery systems in medical, social, and public services with the goal of advancing health equity and health outcomes. And our presenters today are going to be Alicia Bunger and Becky Phillips. Alicia Bunger is an associate professor in the College of Social Work at Ohio State University. Her research focuses on system and organizational strategies for implementing evidence-based interventions, improving service integration, and enhancing access to behavioral health services for children and families. And Rebecca Phillips is a PhD candidate at the Ohio State University College of Social Work, where her scholarship focuses on innovation, adaptation, and implementation approaches of HHS organizations and their effects on workforce functioning and well-being. And the team at Ohio State University examines the use of regional multi-sector governing boards to help organizations work together in coordinating services for children and families in rural areas. Using a combination of qualitative and quantitative methods, the team will examine the influence of regional boards of cross-agency communication, adherence to evidence-based guidelines, and attainment of key program goals, including family reunification. And I'm going to go ahead and turn it over to Alicia. And just for everyone to know, if you want to ask questions, please reserve it for the Q&A chat box, and we'll get to that at the end of the presentation. Thanks.
Right, good morning or good afternoon, depending upon where you're logging in from. So I do this every time. You would think I'd get the hang of it after 2 years, but I haven't. Do you see my slide or do you see my notes screen?
Slides.
Super. Okay, we're going now. Right, so thank you so much, Dina, for introducing us. And we wanted to thank the S4A and the Robert Wood Johnson Foundation for allowing us to share our work and also for supporting our work, because it's allowed us to bring together a multidisciplinary team across research and practice together to dig into some of these more complicated questions around system alignment and service delivery. So I first wanted to express my deep gratitude to our big team here across Ohio State University, as well as University of California, Berkeley. And we represent a team of social work, public health, public administration scholars that work very closely with our partners in child welfare, behavioral health, and what you'll soon learn a little bit more about, our alcohol, drug, and mental health boards here in Ohio. So thank you very much, everybody. We're excited to be here. As Dina mentioned, our objective for our S4A project was to examine the role and the impact of public behavioral health boards, the role that they have for aligning child welfare and substance use treatment systems for program implementation. The specific program that we focused around is the Ohio START program. So first, a little bit of background. Ohio is #1 for some of the wrong reasons, unfortunately. The opioid crisis has really hit us hard here in Ohio, and it's contributed to extremely high overdose death rates here in the state over the past 10 years. And that opioid crisis has not abated much, especially in the wake of the COVID-19 pandemic. misuse, regardless of what type of substance, affects parenting. Around the same time that we saw an increase in the number of opiate overdose death rates here in the state, we also saw an increase in the number of children who are coming into foster care because of parental substance misuse. Unfortunately, parents who come into the child welfare system because of substance misuse concerns often don't fare well. We miss their needs a lot of time, and we miss opportunities to connect them with treatment. And these families ultimately don't have the kinds of outcomes, the child welfare outcomes, that we would like them to. There's a high likelihood that parents will have substantiated allegations of child maltreatment. There's a high likelihood that parents who are in the system because of substance misuse will have their children removed. And there's a lower likelihood that parents will be reunified with their children. And those are pretty devastating consequences. One of the main reasons for those poor outcomes for families that are affected by substance misuse in the child welfare system is around timelines. So once a family comes into the child welfare system, especially if their children are removed by the courts and placed in an out-of-home placement, that parent usually has about 12 months to make progress on their case plan before there's a determination about whether the safety risks that led those children to be removed, whether those safety risks have been addressed sufficiently. And oftentimes those safety risks are about substance misuse and the parenting impacts that substance misuse has. So, as we all know, it takes, there are long wait lists for substance use treatment. And a lot of times it takes a couple months, and for some families, even more for them to reach a point of recovery. So that 12-month federally legislated time frame for child welfare case progress is often insufficient. But we're not going to do anything about those timelines, at least from the federal government. So instead, Ohio has been focusing on how do we increase or how do we expedite the identification of families who have substance use treatment needs, and how do we get them engaged in treatment quickly, and how do we wrap around the services? How do we wrap services around those families so that they can reach recovery within that 12-month timeline and be reunified with their children? In 2016, at the time, Mike DeWine, who was Ohio's Attorney General, who's now our governor, initiated the Ohio START program. And START stands for Sobriety Treatment and Recovery Teams. It's been adapted slightly here in Ohio, and the RT at the end stands for Reducing Trauma here locally. It's an evidence-based intervention that's been very promising in other locations for helping to expedite parents' access to substance use treatment from the child welfare system. It increases the likelihood that they'll receive medication-assisted treatments, and it helps improve the likelihood that they get reunified with their kids. We began implementing Ohio START with a cohort of 17 counties back in 2017 now. It feels like it's been a lot longer, but it's been 5 years. And today, Ohio START is active in 50 counties across Ohio. It's been rolled out in cohorts. And so there's a map there. And at Ohio State, we've been involved in assisting with the evaluation of Ohio START since then. So Ohio START is what's called a service cascade. It's a sequence of evidence-informed steps that begins with an evidence-informed substance use screening tool. There is a shared decision-making meeting that happens with the family shortly thereafter if a family scores above the threshold on that screening tool. They have weekly face-to-face visits with a designated caseworker from the child welfare system and a family peer mentor. And this is a specialized individual who has lived experience of both reaching recovery and child welfare experience. So this is an addition to the system for the START model. So this intensive joint work between the caseworker and the family peer mentor. At this point, the family is then referred to treatment, and the goal is to get them to their first treatment appointment within 38 days of initially coming into the system. So there are some really key milestones and some key engagement work that happens in those first 38 days. And then they continue on in intensive treatment and whatever other kinds of services that they need to make and maintain their kids at home in a safe environment. 38 days is quick. Issues that's arisen though in implementation of START is that this is a tricky model to implement because it requires collaboration between the child welfare agency and at least one substance use treatment provider in the community. There needs to be that strong relationship so that they can get parents connected to care very quickly. And that collaboration can be challenging because the child welfare agency, they need to identify a provider, they might need to negotiate that agreement and establish communication channels, and then figure out how they're going to manage that case intensively. There's also a lot of meetings where folks come around the table with the family to discuss case progress and make adjustments as needed. So collaboration is really vital for START implementation. This is very different though, depending upon the context of the county that we're implementing in. And so Ohio is I love Ohio as it's a great case example. We have 88 counties and 88 completely different ways of doing everything here. So from a research standpoint, it makes it really fun because there's so much natural variation. My practice partners feel very differently because of all that variation. But what we were seeing in the very early days of START implementation was that this collaborative relationship and the way that it was established looked very different across some of our more rural counties compared to some of our more suburban and urban counties. And we think it has something to do with the robustness of the behavioral health system and just the lack of resources that we see in rural and some of our more Appalachian communities here in Ohio. On during planning, in some of our conversations with our stakeholders, we were identifying, who can potentially help these child welfare agencies figure out who and how to partner with their substance use treatment organizations. Here in Ohio, we have alcohol, drug addiction, and mental health boards. So we have a very strong tradition of home rule here in the state. Again, we like to do things differently depending upon the county. It really allows for local tailoring. And many of our counties have tax levies, either on property tax or sales tax, and those are set aside for behavioral health services. And so in order to administer those funds, there are these local ADMH boards or behavioral health boards that have been set up to administer those funds. They also have they also have local authority over behavioral health service planning. So they do regular needs assessments, they understand sort of the scope of needs within their community, and they help inform planning around services. So they're familiar with the local service landscape in each of our counties. We have 50 of those boards here in Ohio, and they are quasi-governmental. So they are usually affiliated with a county, or in the case of those that are joint, that are multi-county boards, they're quasi-governmental. And as we came to understand these boards, we really see them as serving the public health function in the behavioral health service system because they are responsible for managing those local networks of behavioral health treatment organizations. So our study had 3 aims. We wanted to understand exactly how are boards helping to align systems for START implementation, what specific strategies are they using, how engaged are they? We wanted to understand how that board engagement varies across different county contexts, since we had that hunch that things look a little different in our urban and rural or small and large counties. And then we wanted to understand what kind of impact might this board engagement have on service delivery. In particular, does it make a difference on how quickly partnerships are able to be executed, how strong they are, and whether it makes a difference for implementation of the START program? We used a mixed methods, multiple case study approach, and we're drawing on data that we collected from 17 county systems. Now, a quick caveat, originally, our S4A project was going to focus on the 15 counties that we're implementing as part of cohort 2, so the second rollout of START here in Ohio. And then COVID happened. And it greatly affected our ability to recruit counties. We had some major data collection delays. And so in light of that, and in consultation with our program officers from S4A, we decided that we were also going to leverage our engagement with 8 counties that we were engaging as part from cohort 1 in a separate NIDA funded study. So we were able to ask some of our S4A questions with our cohort 1 counties that had been rolling out since 2017. So that's how we were able to reach our 17 counties sample, despite, the world completely changing as a result of COVID. So we're really grateful that we were able to do that. And so we were also able to leverage what we were learning from the S4A project in our NIDA study. And you'll hear a little bit more toward the end about how we're integrating the findings from those 2 studies together. Did a lot of data from this project. So this is a mixed methods, multiple case study approach. Our county is a unit of analysis. And we wanted to understand engagement strategies and collaboration challenges. So we've done 48 small group interviews in each of those 17 counties, 48 total, with about 104 individuals. We did small group interviews with teams that were implementing START in the Child Welfare Agency. We did interviews with their behavioral health partners. And when we were able to, we were also interviewing and talking with folks from their regional behavioral health board. We also collected a lot of formal partnership agreements, both contracts, MOUs, other types of interagency agreements, so that we could understand exactly what was negotiated. We also drew on a lot of publicly available data to better understand the county context, including census data, local data from our Department of Health and Mental Health and Addiction Services here in Ohio to understand the severity of the opioid crisis, information about child maltreatment rates in every county, so that we could better understand some of the local drivers of service needs. We also, you'll hear a little bit when we get to aim 3 about the OSU Needs Portal. And so this is a local database that, that's been adapted for use in START implementation, and it's where we keep, it's a case records information system that's specific to START, that allowed us to pull some information about implementation. And we also did some worker surveys in each of the child welfare agencies to understand how caseworkers and their supervisors were understanding the strength of the collaborative relationship with the substance use treatment provider. We used a template approach. We collected a lot of data, and then the challenge was knitting it all together. And we had a series of stakeholder meetings over the summer where we calibrated our data. And so essentially we brought our community-based stakeholders together for a whole bunch of meetings. It was very painful for them, and I apologize for that. But we reviewed our data. We talked about what was meaningful, additional data that needed to be brought in. We reviewed different types of indicators to figure out which ones were most salient, which ones they trusted the most, if there were relevant cut points that we should consider. And it was a really fruitful discussion that helped us get a much better sense for what we were seeing in our data and how we might put it all together at this stage. And so after that, we were able to examine patterns in some of the qualitative and quantitative themes, even though we only had that 17 county sample our study. So let's get into the good stuff. The first question that we wanted to answer is, what strategies are boards using to help align child welfare and behavioral health systems? And one of the first things that we heard off the bat was that these ADAM-H boards were using, they really set the tone for collaboration in general. So there were some general approaches that they were using that were not specific to the START program, but that pre-work had really set the stage for programs like START to be implemented. And so we heard about that in almost all the counties. 16 of our 17 counties were able to talk about how their ADAMH board had done something before START rollout that sort of helped them build on that for their own program. A lot of times these were more general strategies that they used. I really appreciated this framework May, Scutchfield, Bandari, and Smith put out there around local public health entities and their main functions. And our assertion all along was that these boards serve the public health role in the behavioral health system. And so it was fun to sort of see and hear about the general strategies that boards were using and how it actually mapped onto the same things that local public health entities were expected to perform as well. So understanding community needs and service availability, building community support for policy and other types of coordinated activities. And again, also engaging in a lot of assurance activities like disseminating information, developing centralized referral systems. They provide legitimation for their providers. So a lot of times it was mostly these assessment activities that were most commonly referenced, but there were a bunch of other more specific strategies that we heard about. So just in their everyday operations help set the stage for START. When it came to START specific board engagement, so these were very specific roles, so exactly how folks from the ADAMH board, the behavioral health board, were involved in START implementation. We heard a lot of inconsistencies across counties, which is not news to anybody from Ohio. And so during our data calibration meetings over the summer, based on the information that we learned, it really helped us split counties into 3 groups. So where there was no specific START engagement from the board, where there was some sporadic engagement, and where there was regular engagement. And so there were 5 counties, or 30%, where there was just no engagement of boards in the START program. And let's not jump to conclusions. Engagement goes both ways, right? But for the most part, 70% of our counties had their ADAMH board involved in START implementation to some degree. Generally, these relationships were fairly good, so it wasn't an issue of having poor relationships with the ADAMH board. And we heard about 3 different broad types of strategies that were used to engage or have ADAMH boards engaged in START implementation. So they were engaged in planning by sharing general information about behavioral health services. 41% of our counties had an ADAMH representative engaged on their steering committee. Of note, all of our START counties are encouraged to have an ADAMH representative on their steering committee. So that's where we are with that one. We also heard a lot about brokering and how ADAMH boards helped specifically broker the relationship between child welfare agencies and behavioral health providers in their communities by providing information about those partners during provider selection or partner selection, providing a connect and making that introduction in some cases, or making a recommendation about who the child welfare agency might want to talk to. We also heard about, in 23% of our counties, so 4 of them, we heard about how ADAMH actually provided resources to the START program to either, in one case, they paid for the family peer mentor position. In other cases, they provided resources to START clients. So oftentimes those ADAM boards serve as payers of last resort and might be able to cover services and other types of concrete resources that are not otherwise available in the community. So for the most part, we saw inconsistent engagement. Although a lot of variations in the way that those START board or those ADAMH boards were engaged. We also heard a lot from our counties about, at least on the child welfare side, they knew who their ADAMH board representatives were. Some of them even went out to dinner and drinks with each other. They had these established relationships, but they just weren't sure how they could, how do you think we should be working with the ADAMH board? And likewise, when we talked to folks from the ADAMH board informally afterwards, there were some who felt very frustrated. They said, we are a resource here and we haven't been, we're a resource that hasn't been tapped as strategically or as much as it really could be. So there's some of that knowledge gap there about how exactly, what would be the benefits of partnering together that needs to be potentially negotiated a little bit better within our counties. As we were taking a look at these strategies, it struck me that some of these START-specific board engagement strategies loosely map onto network management strategies. So if we think about these ADAMH boards as managing networks of providers, that's one role that they can provide when specifically implementing a program like START, by helping identify partners, brokering those relationships, and mobilizing resources, which is what we've been hearing in the counties that are engaged with their ADAMH boards and START implementation. One additional type of network management strategy that we did not hear about was about ways of incentivizing alignment. So that might be one other way that we could be helping behavioral health boards or other similar types of coordinating councils and entities in these counties set up system alignment for program implementation. Second question that we wanted to understand, okay, so we're figuring out these are the ways that boards are engaged so far or not engaged, and this is how they're helping start implementation. Does it vary across different county contexts? And so I'm going to turn it over to my colleague, Becky Phillips, who's a doctoral student and has been involved with the START program since the beginning. So I'm going to mute myself and turn it over to Becky. Becky, tell me when you want me to advance the slide.
Sure. If you want to go ahead and go to the first one, kind of getting into the details. The next slide, please. So as Alicia had mentioned earlier, we know that there's a lot of variation in Ohio and the way counties do things within various systems, but including child welfare and behavioral health. So drawing on those collaborative governance frameworks and prior literature on how interorganizational relationships work, we suspected that the way boards engaged and their role in START implementation might vary depending on particular characteristics of the county system, in addition to how the community needs and resources available might vary depending on the size and other features of the counties where START was being implemented. So as we mentioned earlier, we found that ADAMH boards were engaged in START implementation in 70% of the counties, but of that percentage, only about 40% were engaged on a regular intensive basis. So we decided to delve more into the qualitative data to kind of try to figure out some of the whys as to why we saw this variation in the level of engagement and the kinds of strategies and activities that ADAMH boards were engaging in for START implementation. So we found from our interview data that there are a few themes around how the size, specifically the population dispersion of the counties might play a role, particularly due to how the number and kind of history of behavioral health resources in the community. So it might not be a surprise that larger counties tended to have more providers. And with that came some unique challenges as well as benefits. Logically, it seems to make sense that the more providers there are, the more services are available for families. But with that can come some challenges, particularly for child welfare agencies around engaging particularly with new providers in the area and being able to vet providers and make sure that the services they are referring families to are appropriate and of high quality, and that they will be able to receive the communication and the information that they need from these providers regarding the family's progress with their case and meeting those START goals specifically. And so we found that that was a challenge that ADAMH boards could be helpful with in terms of facilitating those partnerships and helping provide child welfare agencies with some of that vetting information that they might need. Alicia, if you could go to the next slide. So yeah, as I mentioned, we looked at specifically county sizes as a potential area of variation. We used size as specifically in terms of the population dispersion, so small or medium being about 50,000 or fewer people, and then the medium to large between 50,000, 100, 200,000, and metro, major metro, larger than that. So we saw that based on those categorizations, that did seem to play a role in the variation we saw in ADAMH board engagement, not necessarily in whether or not they were engaged, but the amount of engagement, which seemed to matter. So we see that the larger counties tend to have that more regular engagement, which might make sense given the amount of providers that they were looking to potentially partner with for START. Meanwhile, the smaller counties the engagement seemed to be more sporadic. So next we delve more into the qualitative data to figure out why that might be. Alicia, next slide. So it seemed like when we looked at the qualitative data in greater depth, we noticed that based on the descriptions of how boards were involved, that the challenges might be different based on the size. So as I mentioned, in larger counties, they tend to have more behavioral health resources, particularly a lot of new ones that have come into the area due to the opioid crisis. And so on the flip side of that, in smaller counties, the minimal resources available tended to create challenges with identifying and creating partners in general, but that the ADAMH board, they were often unsure of if or how to engage the board around START, what role other than potentially funding the ADAMH board could play. They really often viewed the role of the board as primarily fiscal. And so they felt that board members were available to and will be responsive if they reached out for help with START, but they didn't know what to ask or why or how to reach out. And meanwhile, we heard a much different story in the bigger counties in terms of START, that they were regularly engaged at the table for steering committee meetings and were particularly helpful in connecting child welfare agencies with appropriate SUD providers. And so it seems that the challenge with that could be that if certain agencies have better or poor relationships, either with child welfare agencies or the ADAMH board, that could create some different kinds of tensions within the community. So Alicia, next slide. So kind of in summary, based on what we were finding in terms of the role of ADAMH board in engaging counties with START implementation and other implementation of other similar programs, in larger counties, board engagement could be particularly useful for brokering those partnerships, both identifying ones that would be appropriate and of high quality for the START or other program referrals. Meanwhile, in small and medium counties, boards may need to use more of those direct active strategies to engage stakeholders to explain what their roles could be, to start to build those relationships between boards and the child welfare and behavioral health providers. So, and then from there, be able to support communication and collaboration across communities. Okay, and I'll turn it back over to you, Alicia.
Thanks, Becky. So our first question was, how are boards engaging in START implementation? Our second question, and we heard about these general strategies and these very specific START strategies. Our second question was about how those strategies vary across contexts, and we started to see some variation about there was more regular engagement, especially in the larger counties. We think it might have something to do with the size of the service delivery system that needs to be coordinated there. And then our third question was, okay, well, does it make a difference? So originally, we theorized that when the ADAMH board, when these local coordinating bodies are engaged in system alignment, it might help expedite the relationship that's established between the child welfare agency and substance use treatment provider. It might lead to a stronger relationship between those two providers, and that it also has an impact on the way that START is delivered. In particular, it might reach more families. We might have closer fidelity to the essential elements of the START model, and it might lead to more timely substance use disorder treatment. And ultimately, we think that has implications for client outcomes. So that was the assumption that we started with. So So first we looked at collaboration, both the timing of the partnership and how quickly they were able to begin serving families after they started planning. And this was drawn from data that we collected, or the actual contracts and MOUs, the date that those agreements were established, and then the date that the first family was served. And so 41% of our counties were able to serve the first family within 6 months of beginning that planning. That's a pretty quick startup if you think about how complicated implementation can be. And 47% had an MOU or a contract in place before serving the first family. So a lot of these counties were brought in families before they had that designated provider in place or had been able to fully execute a contract or an MOU. Might be because in some of these more rural communities, there's a history of strong collaboration and they felt comfortable sort of flying without a document binding the two of them together. In terms of collaboration strength, we drew on our interview data to understand mutual satisfaction between the child welfare and substance use treatment providers. And there was, they're satisfied in 76% of the counties. There was mutual satisfaction with their relationship, which I guess is pretty good. And we also measured the strength of collaboration in our caseworker surveys using the Wilder Collaboration Factors Inventory because of the complicated nesting of the data. What we ended up doing is taking a look at counties that had average collaboration scores or above average collaboration scores. So we had about 30% of counties that had above average collaboration. In general, collaboration was rated pretty strong. So we want to see, okay, well, does this vary across counties with different levels of ADAMH board engagement and START implementation? And so what we saw, we didn't see much variation in the strength of collaboration, but we did see that counties with boards engaged in START implementation, they seem to do better on timing their program launch. So there's a higher percentage of those with board engagement that were able to serve families within 6 months of their start, and a higher percentage had their MOU or contract in place before serving their first family in the program. So that gives a little bit of support to this idea that, hey, perhaps we can launch the program a little bit more quickly when we've got our ADAMH board partners at the table. I also wanted to understand the impact on implementation. So I want to give a shout out to our evaluation team here at OSU, led by Bridget Freisteller, and Elenom Delore has been managing the OSU Needs Portal since the beginning of START, and this tracks all case data for Ohio START. And what's really cool about this is not just the fact that I figured out how to put a QR code in a presentation, but we have a public-facing dashboard so that our county and state and external stakeholders in START can take a look at any time to see where we are with START implementation. And so if you're really curious about it, you can hover your camera over the QR code and it will take you to the website where that dashboard is located. Anywho, we drew on that dashboard and the data that populated from the needs portal to understand implementation outcomes and service delivery outcomes. So we were interested in reach or penetration. So to what degree are we serving families in the community? This is usually captured in terms of the number of families served. So across our 17 counties between March 2019 and August 2021, these 17 counties served 352 families. On average, counties were served about 20 families each, although that varied between 2 and 48. But incidentally, it didn't seem to vary across levels of board engagement. We also took a look at fidelity, so the degree to which each of the core or essential elements of START were being delivered in each county. And so this, on the right side of the slide here, you see a bar graph depicting the percentage of families receiving each of the essential elements of START. So UNCOPE is the initial screening. So it's used to identify which families are eligible for START. So of the families in START, 95.7%, at least within this particular sample from 17 counties, we got the screening done for nearly all of the families, which is great. The next step was the shared decision-making meeting. So can we bring the family together with all of the service providers or with the caseworker all together to engage them in START and agree we're going to engage in this program and move forward with the case? 80%, that's great. The next step was a qualifying contact with their family peer mentor. So a quick turnaround where they're meeting in person, even during COVID, with their family peer mentor, 70%. And now here is where the model starts to drop off. The next step was a treatment referral to substance use treatment, 55%. Do they have a treatment visit logged in the needs portal? 42%. And when we take a look at all of these essential elements together, 36.4% of our families from these 17 counties were receiving all essential elements. So what our takeaways here is fidelity to the model drops off with each stage, which is not unusual. This is a sequenced, interdependent, and a complex type of intervention. We know from prior demonstrations and implementation of other types of service cascade models like this that try to link services in one system with services in another, that they are very vulnerable to implementation challenges, particularly at this point where families transition from one system to the other. And if you can believe it, these results are actually better than the last service cascade study that I led. In that case, we were linking kids in foster care from child welfare to mental health treatment. And even despite intensive implementation efforts, our treatment rates were actually lower than we're seeing in these 17 counties. So this is both troubling and promising all at the same time. But it really points to, these models can break down at any time, particularly at that transition point. So we wanted to see, well, are some counties doing better than another, particularly by whether or not they have their ADAMH board engaged in START implementation? And no, it didn't seem to matter. So it didn't seem to matter in terms of program implementation. The last thing that we wanted to take a look at was timeliness. So as I mentioned when I introduced START to begin with, the goal is to connect families. So the families that we are connecting with substance use treatment, are they able to connect within 38 days? That's the gold standard for START. Oh, we've got a co-presenter with Becky. I think that's Rogue the cat. Come one, come all. We'll grant co-authorship status to cats and dogs. So we were taking a look at the date in which that first treatment was delivered and logged in the needs portal. So a caveat. Data entry is always a problem. And for 18% of our counties, so two of our counties, there wasn't enough treatment data entered to be able to make a determination. And so we're not sure if those empty fields are because there was no treatment delivered or we just weren't able to record it. But we feel pretty confident about the data that we do have, and considering previous experiences, and the fact that these rates of treatment are actually kind of higher than what we've seen in other instances, we don't feel that bad about missing data. There's some bad feelings about missing data, but maybe not too many. Anyhow, so on average, with the families that were involved in these 17 counties, they were reaching treatment. The ones that we had treatment dates for, they were reaching treatment within an average of 27 days, which is super fast, especially considering wait lists. Oops. Yes. And so there didn't seem to be much variation across whether or not the ADAMH board was engaged in START implementation. We also took a look at the percentage of counties that were consistently making that 38-degree or that 38-day mark. So 59% of our 17 counties in the study were getting their families to treatment with it, the ones that they were getting to treatment. They were getting them there on average within that 30 days. And what we see a little bit is that there's a slightly higher percentage getting their families in within that benchmark with more sporadic and regular board engagement and START implementation, but we don't feel entirely confident about those results quite yet. So in general, across our three aims, some of our key takeaways is that boards are engaged in START implementation, but the regularity with which they are engaged really varies, and the specific types of strategies that they're using to help implement START varies. A lot of times this is very passive involvement, and that might be due to this, this sort of information asymmetry. Our child welfare folks might not know exactly all the things that their behavioral health board can help them with START implementation. They might not know what to ask, and they might not have been invited to the table quite yet, or with the same regularity that they might need to be. We see that there's greater board engagement, particularly with brokering activities, in larger systems with more robust behavioral health services. And that the board engagement might really help expedite partnership execution and program launch, although the more distal effects on implementation and service delivery are not quite clear. So we think that there might be more proximal benefits of engaging behavioral health boards in system alignment. Our next steps, and what we've been actively engaged in since the summer, is we're using the findings from this study as well as our NIDA study, which focuses more on the specific ways that child welfare and behavioral health organizations are collaborating around implementation. Our goal is to create a toolkit, so a collaboration for implementation toolkit, or collaborating across systems for program implementation, the CASB toolkit. That's what we've been working on. And we're including a module that speaks specifically to how child welfare agencies might be better engaged or engaging their ADAMH board or other types of coordinating bodies. So we're going to include a brief, provide some specific examples for actually working on scheduling a meeting with some of our representatives from different ADAMH boards around the state to put together, okay, so if you think that you've been underutilized, let's put together some guidance for child welfare agencies for how you think that you could be really engaged and really supportive of the START program. So to encourage a little bit more communication back and forth between the two systems. And we're also going to be including some recommendations for selecting those board engagement strategies. One caveat, one thing that we heard about related to brokering. So while these coordinating bodies can be really useful for helping child welfare partners vet different providers and figure out who they want to engage in START implementation, one concern that potentially pops up is that it is about favoritism. And so from the perspective of behavioral health providers in the community, there is some tension around, about favoritism around particular providers. So even though brokering might seem to be particularly useful for helping support START, we wanted to acknowledge some of the tensions and the small p politics around some of these network coordination approaches that we've been talking about for START implementation. So those are some things that need to be addressed and ironed out a little bit more robustly. So with that, I'm going to pause and see what questions you all have.
Thank you, Alicia. That was a very good presentation. I know I have a lot of questions on it. One question we have from Elizabeth: do you find boards to be representative of the communities they serve, and how does that impact their ability to be effective connectors and agents of engagement?
I like that question a lot. So ideally, boards are these quasi-governmental institutions. So most of the time when we're talking about board engagement in START implementation, we're talking about a staff member from that board that's engaged. So a professional person, a lot of these folks have years of experience directing behavioral health organizations. In some cases, we have board staff who are actually from the local child welfare agency and have significant professional experience there. So when we're talking about the people at the table for START implementation from the boards, we're talking about professional staff. That said, those boards are really encouraged to represent the voices of their communities. And there's significant variation across these 50 boards in terms of how they do that. And that's not something that we looked at specifically in terms of representativeness and the degree that they reach out and reflect the voices and the demographics of their community. But isn't that a great direction and a great question that potentially we could answer empirically with our data? So thanks, Elizabeth.
Alicia, is it okay if I chime in real quick?
Yes, please.
Just one thing that it seemed to contribute to some complication in terms of folks' relationships with their boards is the fact that although we have 88 counties in Ohio, only 50 boards. And so in some cases, particularly smaller counties, boards may cover 2, 3, 4 counties. And so that seemed to complicate relationships between those small counties, child welfare agencies, and the boards, just because their attention had to be split. And so that seemed to be an area of potential complication in terms of how representative and how engaged they were able to be with their counties.
So glad you remembered that.
Actually, that goes right into a question that I had. Do you know the numbers of multi-county versus single county boards across your small, medium, large counties? Because that's exactly what I was thinking, is maybe some of these smaller ones have multi-county boards that have to serve multiple counties. And that's why you're seeing this discrepancy in their like sporadic, non-regular engagement.
No, I can't tell you off the top of my head, but we know.
Do you have the
You know
map?
off the top of your head, Becky?
Did you have a map towards the beginning of your slides that I think at least gave the numbers? It might not break it down by, but I think in general, the multi-county boards would be specifically with small counties because there are often not enough folks to cover one county, and so they end up covering multiple. Yeah, see, 30 single. Yeah.
Yep. Oh, she's good.
Why keep me around?
I also had another question. I really like how you separated out all of your research questions. And this one kind of gets at your number one question and your number two. You were looking at characteristics of board engagement, and then you separated it out by characteristics of the county. For the rural counties, do you know what the counties that did have good in board engagement for those small counties, what were some of those like things that they said that were working for specifically those rural counties that others could eventually adopt? I don't know if you went into detail on that, but I was very interested in what potentially that is.
To ask Becky to weigh in on this.
It seemed from what we've seen thus far, our dive into the qualitative data, it seemed that in those small counties where it was working well, part of it was a pre-existing relationship. And Alicia kind of talked some about the, the outside of START or outside of even a professional role, like in those small counties, everyone seems to know everyone. And so if those relationships are positive, that helped to kind of facilitate that partnership or that engagement because they already knew who those folks were and they felt comfortable reaching out to them because they knew them more personally. And in counties where maybe those relationships weren't so healthy, that could therefore be kind of an area of tension and a barrier to engaging them with implementation of particular programs. It seemed that like a lot of the small and medium counties, the child welfare agencies knew these folks primarily through a fiscal kind of capacity. And so START had actually, in a lot of cases, helped to, its implementation was improving the relationships because it gave a specific kind of entry point for a different kind of engagement outside of maybe just funding. And so it's interesting how in some ways START actually improved relationships between child welfare agencies and their ADMH boards and behavioral health providers instead of the other way around. But then it became this iterative because they had that engagement, then they were able to continue, they had a kind of foundation to then build on that relationship and continue to improve it.
All right, we have another question from Anne. What did your worker surveys tell you about CW perceptions on collaboration?
Oh, for this particular one, we did not see a lot of variation in responses. Generally, collaboration was rated fairly high, and it was rated fairly high consistently. So from a research, I think from a practice perspective, that suggests to us that there's satisfaction in the relationships, and that was reflected in some of the qualitative interviews that we did as well. At this point, a lot of them had worked through bumps in the road that they might have encountered in developing those relationships. So we just didn't see a ton of variation in those scores. So from a practice perspective, that's great. From a research perspective, not so much, because we want that variation so that we can understand relationships. One of the things that we still need to do is dive into the specific subscales of the Wilder collaboration factors inventory. There are 6 subscales there. So there's potential for us to dive deeper into those to understand if maybe there's particular dimensions that vary a little bit more. Yeah, they like it.
I also had a question on, you had a graph, I think it was slide 28, and it was looking at each of the core elements that were needing to be delivered. And you said that you didn't see that there was a variation in the core elements delivered by board engagement. And I was wondering if you had any rationale as to why.
I think implementation is just really hard. I think the board engagement is really what we're seeing in the data so far, is that board engagement is really helpful for setting up the building blocks for start implementation and helping to align systems. But there are so many other factors that go into implementing the program, delivering services, engaging families, especially in substance use treatment, that I think affect the way that the START model is delivered to families ultimately, that might be affecting these results. So it's not that I don't think it matters. I think it does. But I think that there are just so many other explanatory factors along that, along that chain of events that can also shape the way that services are delivered. So I think that might be what is explaining, but I don't know. And I'd be curious to know if others have hypotheses or thoughts that occur to them that they might want to share too.
I think particularly in the rural counties that indicated very few providers just existence. In some counties, any behavioral health or substance use provider, they actually have satellite offices. They're not primarily based in a county because the county is so small. And so in terms of having someone to refer these families to who has the capacity to pick them up in a timely manner and see them in the time frame that START recommends, I think that can be a particular challenge for some of these small rural counties.
Yeah.
Yeah, I was also interested in if you guys are thinking about looking for future iterations, you look at population or size of the county, but are there any other county factors that you could maybe take into account with some of these? I mean, I'm not specific in the research of, substance abuse or families, but maybe something like income, homelessness seems to be a huge factor in some of these. So maybe that has something to do with this relationship you're seeing.
Some of our preliminary analyses that are being done for the NIDA project, that's looking at the specific collaboration between child welfare and behavioral health, some of the things that seem to be popping up there, and again, this is super preliminary, is rates of neonatal abstinence syndrome. So sort of this larger contextual factor, which we think really reflects, I mean, if you think about neonatal abstinence syndrome, it really reflects the intersection of parents and kids. that might be reflecting the rate or the severity of opioid addiction within these communities and the way that it's affecting families, or at least new moms, or newer families with young, very young children. So that seems to be popping up as something that is associated with the way that START services are delivered. And that might be, we want to dig into that a little bit more. But that might be driving that might be creating some additional pressure on these communities to get their START program up and running. I will say, this is opiate addiction and substance use in general is a very, it's a very pressing problem in all of our communities. And I think that's really motivating a lot of our communities to want to implement START, and maybe higher rates of those kinds of needs are creating additional pressure to get it off the ground quickly. So that might be something else that we want to look into, in addition to population size too, and the number of providers.
All right, I think we're at about time. Thank you to our presenters for their great presentation, really interesting work. We are going to be sending all of these slides in an email. I would also like to notify everyone about a certificate of completion for viewing this webinar. It will be emailed to you at the end of this session. Next slide. And we do have some upcoming webinars. The next one is on multi-sector task sharing to improve mental health in Harlem, New York. That's going to be February 16th for anyone who would like to join that. The link is at the bottom. And just thanks again to S4A, Robert Wood Johnson Foundation, Colorado School of Public Health for hosting these webinars. And thank you again to our presenters.